Hello, everyone. Welcome. My, my name is Hamid Madavi. I'm with Heart Brothers organization, and I both had a HVAD and a heart transplant. Thank you all for making the time to join us. This is the special event tonight we're hosting, uh, dedicated and focused to people who currently still have the HVAD device. And our goal and objective of this meeting is to create a support space for the HVAD patients and their caregivers. So this is not only open to the patient, but their caregiver. We want to best understand the best practices from HVAD providers and coordinators across New England so they can share the best information they have and how they treat their patients and items they come across. And then we want to really discuss any need that HVAD patients and caregivers might have. And then through this whole process, connect the various HVAD patients in the area so they can, connect and be able to communicate with each other. The panelists tonight, we have Dr. Michael Kiernan from Tufts Medical Center. He heads up their mechanical circulatory support system care. Plus, he's part of their advanced heart failure team and transplant team. Teresa Seeley, she's a registered nurse from Brigham and Women's Hospital, and she's also the VAD coordinator for the Brigham, and she interacts with the HVAD patients. Nathan Traverse is also a VAD coordinator from Tufts Medical Center, and we also have Megan Lopresti. She's a clinical specialist from Medtronics Corporation. She's here if any questions come up specific that she'll try to answer them, and she's also going to be helping in the background as manage the program. I don't know if all of you know Heart Brothers. I'm going to do a quick introduction of Heart Brothers Foundation, do a Zoom best practices, and then I'm going to turn it over to Dr. Kiernan. My only request is that unless you're speaking, please stay on mute because so we can, as we're recording this, so we're going to make this available both on the Heart Brothers website and we'll make it available to the centers and wherever else you may need it. Okay, so let's start with a quick introduction of Heart Brothers. Heart Brothers Foundation, our focus is helping people with heart failure. It was founded in 2014. It was founded by two people. One of the gentlemen's on the call here, Bob Romer. The other one, Patrick Sullivan, can't make it. And our sole mission is to bring resources together to help heart failure patients and their loved ones survive a life with heart failure and all the challenges. As I'm sure you all know, there are many challenges living with heart failure. So Team Heart Brothers, who we are, we're patients, just like you. We're traveling the heart failure journey. And after our transplants, we've decided to give back to the heart failure community. So myself, Bob, almost 99% of the Heart Brothers members are heart transplant recipients. And as I said, our mission is to help and support heart failure patients and their loved ones. For this particular event, the sponsor is Medtronic Corporation, so I thank them for that. So a quick introduction of the co-founder, Patrick Sullivan. He's a co-founder. He received his heart transplant in 2013, so he's actually celebrating his 10-year anniversary. And there's his contact information if anybody wants to reach out to him. He's a great guy, always looking forward to hearing from friends and other patients. And Bob Romer, that's his picture. And we have a unique perspective on heart failure after more than 30 combined years of experience living with heart failure, including the two in the hospital. That's Bob and Pat met in the hospital. They spent a year in the hospital together, and they have made a commitment that if they ever got out of there alive, they would pay it forward and do something to help the patients out. And the rest of us who are members of HeartBrothers, we sort of had the same feeling when we're in hospital to help out and pay it forward. So that's what the organization is really based on. And our firsthand understanding of the overwhelming physical and mental and financial stresses that affect heart failure patients and their loved ones. That's why we have dedicated our lives to helping heart failure patients. So I just want a quick rundown of our programs. If you're not familiar with it, we have Heart of Survival. So we provide gap assistance and tools for patients and families to help them survive long-term hospitalization. We obviously can't pay them insurance bills or pay it directly for care, but we provide additional supplemental funds to help people out with lodging, with transportation, with maybe a special diet, whatever we can to help them. So we have a team, HeartBrothers. Those are our volunteers. They're all transplant survivors. We call them ambassadors. And we do face-to-face interaction with patients and families, as well as fundraising efforts and raising organ donation awareness. We have about 70 ambassadors, and we're available for a phone call. Most of us are spouses, or our caregivers are available to phone call to talk with your caregiver. And we have both ladies and gentlemen as members of our team. So if anybody has a preference to speak with a lady or any kind of special, it's a very diverse group, so we can accommodate any kinds of needs or preferences. We have HeartBrothers House, which are 2 downtown Boston apartments, and we provide short-term housing options for heart failure patients. It's on a first-come, first-served basis, and usually you make contact through us through your hospital social workers, or directly you can go to our website at heartbrothers.org and make the contact. It used to be $49 a night, but due to the ever-increasing rent in Boston, I think at the beginning of 2024, we're going to go to $75 a night, which is not bad still, for including parking for a pretty nice 1-bedroom luxury apartment in downtown Boston. So, and we have a patient support group, and this meeting tonight's an extension of that. We host a monthly virtual patient-focused meeting, and we host it with a rotated group of partners at transplant centers. We'll have social workers, we've had dietitians, we've had cardiologists. When it was in the heat of COVID, we had a couple infectious disease doctors to be there and just talk with the patients. And it's also just a social gathering. So please come and join us. Second Thursday of the month at 6 p.m. We have a heart failure blog, which is basically bringing those in the heart failure community together with up-to-date heart failure news. So we try to make a point of keeping the blog up to date. Again, you can access that on our website, heartbrothers.org. And organ donation awareness. We work with New England Donor Services to promote organ donation. We have joint events with them. They support us, so we want to bring awareness about organ donation as well to them. And so just a quick Zoom best practices: maximize your screen size, please. Comments and feedback in the chat. Got a couple people monitoring the chat. And if you have questions, you can put them in the Q&A section as well. And please stay on mute when you're not speaking. And just here's how you can contact us on Facebook, Instagram, and I guess the other one is which one is that? X. And thank you for the time. And with that, I'm going to put the program back up and turn it over to Dr. Kiernan, who's going to basically moderate and be a panelist in the discussion. So thank you very much.
Great. Thank you, Hamid, for the invitation to be part of the group tonight. It's nice to be able to have the time in a more relaxed setting, connect with patients directly, as you know, when you're here in the hospital or in the clinic, our things can be very rushed given time constraints. So I've been looking forward to this opportunity to connect with people directly. It is a small group, so ideally let's keep it casual. Feel free to interrupt and ask questions. Don't be afraid to ask questions. If you have a question, I can 100%. One thing I've always learned is if I have a question, there's other people in the room with that same question that may be afraid to ask. And this is being recorded, so hopefully it can be a resource for other patients who aren't able to join us this evening. But I do want to, Hamid, I want to thank you and your Heart Brothers. Makes the work that we do possible. As we grow as a program here at Tufts and across, we have other hospitals participating in this as well. I can tell you the feedback that we get from patients regarding the support that your group provides is just always incredible. It's one thing for me to try, when we talk about in the concept of medicine was called shared decision making, meaning engaging patients when we try to make these difficult decisions about whether an LVAD is appropriate. It's really challenging, and it's one thing to hear it from a physician or a nurse versus hearing it from somebody who's walked in their shoes. And so beyond the financial grants, which are incredibly important to patients, it's really expensive to get care in Boston. More important is the support and helping people get to that decision about whether or not this therapy is appropriate for them, and to know the reality of it, the good and the bad of living life with an LVAD. And so, of course, tonight our focus is really talking specifically about the HVAD and to provide a forum for patients who have ongoing support with that specific device. So, again, thank you for all you do. More about myself, just a quick introduction. As you mentioned, I am the medical director of the ventricular assist device program at Tufts. I've been on faculty and in that position for 13 years. So time indeed does go quickly. And as you mentioned, I also am a member of the heart transplant team on the medical side in the heart failure program at large. We'll take a minute just to introduce the rest of our panel members and faculty. So, I'll let them provide their own introductions in terms of where they are and what they do. But Teresa, can you introduce yourself for us?
I am on mute. I'm a registered nurse and VAD coordinator at Brigham and Women's Hospital. I've been in this role for 2 years. Prior to that, I worked in the cardiac surgery ICU as a staff nurse for over 25 years. I was also the clinical educator in the cardiac surgery service. I trained ICU nurses and step-down nurses to care for VAD patients on top of other cardiac surgery procedures. So I've been taking care of VAD patients for since the early 1990s. And I'm very happy to be in this role in an outpatient setting.
Great, thank you. And Nate?
I'm Nate. I work at Tufts Medical Center as an RN. I've been there since 2012. Started on the cardiomyopathy unit, and that's where I was introduced to VADs. And then I worked in the CCU, and I've been a VAD coordinator for 2 years in the outpatient setting. So good patient population. Love to work with VAD patients.
Awesome, thank you. So we do have some, some loose topics as we kind of move through an agenda for the evening. But the first thing that we're going to discuss is kind of the process on our side in terms of caring for patients. So maybe Teresa, you can speak a little bit about what your relationship specifically with the HVAD, the Heartware, or now Medtronic HVAD, has been for you at the Brigham and with your patients that you're caring for at the Brigham.
The experience has been fantastic. And I love taking care of patients, like I said, in the outpatient setting, because as a prior ICU nurse, we didn't really know what happened to patients after they went home with their VADs. But now as a coordinator, we do, we do a lot of education. We do a lot of training with the community. We provide yearly education for our patients who have HVADs. If they want to come in once a year and practice on demo equipment, controller exchange or batteries. I feel like we are a trusted resource to our patients, and we provide reassurance and ongoing continuity of care for throughout the care of patients with HVADs. And all VADs, but HVAD in particular. And we communicate with Medtronics closely anytime we get any new information about HVADs. We will communicate that to our patients and try to provide some reassurance and comfort to them. So it's a close relationship.
I'm just going to pop in. Eddie just asked a question. What is the difference between an LVAD and an HVAD? Are they the same?
Oh, great question. I'll field that if that's okay. So an HVAD is just a type of an LVAD. So LVAD stands for left ventricular assist device. And so the 3 devices that are currently have patients on support in general are the HeartMate 2, which is made by Abbott, what was called the Heartware at the time HVAD, and then taken over by Medtronic, so the Medtronic HVAD, and now the HeartMate 3. Although currently the only one that's commercially available for new implants is the HeartMate 3. But we have a number of patients still on support with the Heartware HVAD device as well as the HeartMate 2. Does that answer the question? So HVAD is just a type of an LVAD. Nate, can you speak a little bit about your experiences with the HVAD?
Yeah, the being in the outpatient world, it's amazing to me how complicated and complex taking care of outpatient HVADs is. It's not always smooth sailing. Being in contact with them is it's a nice window into how care is extended from the hospital to home. And then we don't, at this point, where the HVAD population is smaller than it used to be. So really getting to know these patients and helping them through their lives is very enriching.
Well, so let me follow up on that. And I think it's so in terms of because people have gone on, many of our HVAD patients, as 2 of the Heart Brother members here have gone on to receive transplants. So the number of patients we have in the community has diminished or decreased. We only have a handful of patients. What's your comfort level for continuing to manage these patients since we have less points of contact? And what types of things can you comment on that we do to maintain staff competencies? Because we need to continue to be prepared, right? If a patient ends up in the hospital, to be comfortable, even though we have less touches, so to speak, with these devices than we used to.
Mm-hmm. Yeah, one of our points of emphasis in the outpatient clinic especially is every time an HVAD patient comes to clinic, we do education with them, emphasizing some important points. And that helps keep our skills up to date because we're constantly reviewing with those patients. I feel comfortable, and they do too.
Good. And yeah, Teresa, you just unmuted yourself. So
Well, and I agree with Nathan. We do the same thing, and we also give a VAD yearly competency to our new fellows coming in, and our attendings who don't see HVADs as often as other VADs. So we just do a review of waveforms and just some key education points once a year.
and same thing for your floor nurses on the units.
We have an educator that does do all the training for the floor nurses and the ICU nurses. But we do when we round on the inpatient, and there's an HVAD patient as an admission, we will review with the bedside nurse.
Great. And I can just speak to my experience as the director of the VAD program, we were lead enrollers in the HVAD clinical trials here at Tufts. And, that's something we're still very proud of. As an academic medical center, we strive to continue to get the best technologies available that we can to patients. So we participate in clinical research trials as part of that mission. And at the time, we do feel that HVAD was the best technology that we had available to provide support to people who are struggling with end-stage heart failure. And there's specific things that I personally really still think is the best about that device is how it presents information to me as a clinician. Namely, when you're in the clinic and you're connected to the monitor, there's a wealth of data that's available in what we call waveforms. And so that to me was something we were able to utilize to help diagnose how people were doing and to optimize their device as it relates to making adjustments. So it was a really useful tool and something that was unique to that pump platform. But, just like there are new generations of iPhones, it's probably not a fair comparison because iPhones are not life-saving technology, but you get the iPhone. I don't know where we are now. I think it's the 15. I have like the 10, but it's the new thing available. And so we do frankly have the HeartMate 3. And I think it's been pretty definitively shown that if you had to start fresh, that the risk of certain complications is lower with the HeartMate 3. And there's, so that is now the device. But I can tell you for people that still are living with the HVAD. And what does that mean? Because sometimes I've heard people feel like they're on a timeline that I don't see it as such. I don't think they got shortchanged. I think they had what was best at the time. We don't routinely exchange these pumps, but generally speaking, if you've had your device, you've likely had it for a number of years, and people that do well, generally speaking, continue to do well. And that the risk of adverse events is usually or complications is usually greatest in that earlier period and you can always have complications with any device at any point in time, but those people that are at highest risk of having serious complications generally have them more early, and people that are super responders or what we call thriving with the device, knock on wood, generally continue to do well. So that's kind of the way I've viewed the transitions in the space. And frankly, we have not lots, but we have a number of patients with the HeartMate 2, which I thought at the time was great, is better than what we called the XVE. And then we started using the HVAD, but same thing. We have a number of patients with the HeartMate 2 that I look to be an inferior device to the HVAD. So technologies evolve, thankfully, and within the next year or two, we're participating in the next VAD trial right now with the device called the EvaHeart. I'm not sure that'll be the next device. That's why it's considered research, but there's even new evolving technologies coming onto the market. So hopefully we can continue to improve the care and what's available for patients, and particularly those who aren't waiting for a transplant, those patients that live the rest of their lives with the LVAD in place. And so we really want to strive to continue to improve the care we deliver and learn as we move forward in this field. So with that, let me
Oh, sorry, there are two questions that came through. So one was, can we watch the webinars again? And I believe Hamid said yes, they'll be on the website.
If you go to heartbrothers.org, I think if you go under events, you have the listing of all the patients and webinars and stuff, and we'll put this up there.
Right. And then the other question was from Bob. He said, I met people who had the LVAD and suggested they don't approve of golfing. Your thoughts?
That was for Bob specifically? Okay. You're muted, Bob.
I'm just saying.
Formulating an answer.
I've seen golfing in videos in LVADs, and I don't think so.
You didn't really ever have much of an opportunity, unfortunately, to do it with yours, right? You spent a lot of the time in the hospital with us, but
yeah, I guess, but
so,
I don't think that golfing is with the tube sticking out of you.
Driveline.
It's qualified.
All right, well, it's important. That's what I mean. It's important to hear it from someone who's been in their shoes. I would say as your physician, I would not, that's not something I would restrict. Again, we put in these devices to help people live full lives, meaningful lives. And, that is not something I consider a high risk. We've had other activities that people have identified to us doing that I'm less enthusiastic about, given that people are on blood thinners, et cetera. But, golf isn't one of them. So I feel like if you can golf and it makes you happy, you should. And I don't have a lot of concerns from that. You got to be mindful of your equipment and not try to put tension or stress in the drive line, but otherwise it should be safe to do.
Like I said, is driveline is the key.
For sure.
Yeah, that's what we tell as your VAD coordinator, that's what we tell patients, to avoid any twisting or any motion that's going to put some tension or tugging at the drive line. So hence how hard your swing is.
That's right.
Yeah, I guess you take a medium swing.
Have a good anchor. Make sure it's well secured in place, or wear an abdominal.
Always wear your binder. That's
there you go, the binder. There you go. So, all right. So I'm not, to be honest, I'm not sure so if we have patients, it'd be great for people that have their videos or to speak, but if we could turn it over to, anyone in the audience and ask what your experience has been like with your HVAD, tell us how you're doing and maybe comment on some of your lifestyle before and after the LVAD, and provide your opinion to that question about activities such as golf. Do we have any current HVAD patients on that are comfortable speaking? All right, we may not, and that's okay. I don't want to force anybody to speak out. Well, let me add, one of the things we were going to ask, and maybe we can have Nate and Teresa comment on it as well, but obviously maybe it's not obvious, and I should ask that question, but what does it take for someone to be successful with an HVAD or VAD in general, and other patients can comment as well. And with that, I mean, guess what I'm thinking, but it's more in terms of the support you need and the caregiver, the importance of having someone to help get you through this process. Nate, maybe you can comment first in terms of how you view the role of the caregiver, be it a family member, a spouse, a child, or a friend.
Yeah, I think, just once you have a VAD and get a VAD and go home, you need a caregiver to provide basic care, which is very important, like dressing changes, but also emotional support through what is a difficult process of surgery and recovery. And having somebody with you and doing that kind of support with you is very, very important. And not everybody has that, and that can be challenging, but a caregiver is very important.
And at the Brigham, we try to train 2 caregivers, one main caregiver who will do the dressing change, but it's important to identify that there's caregiver fatigue as well. So if someone needs a break, there's another person that can step in, to provide support as well. But that's an ideal situation. But definitely, Nate, having that caregiver support is very helpful to recovering and continue to do well with the VAD.
Excuse me, there's one question.
Yeah, I was just gonna pop in. Sorry. I was like, no, that's okay.
Megan,
Yeah.
go.
It says, will my energy levels improve? I'm a candidate for the LVAD. My heart attack happened almost 7 years ago. My energy level continues to go down.
Well, I can answer, I can't answer that from the patient perspective. I can answer that from what you know, from the medical perspective, and what I know from the literature and speaking to patients, the answer is yes, right? So whenever I speak to patients, we put in LVADs for 3 reasons. One, to help you live longer, to prevent premature death from heart failure, which we know is a fatal illness. But equally important, it's to help you live better, to feel better. And we know that it dramatically improves quality of life and symptom scores, way more than medications have ever been demonstrated to do for other less severe forms of heart failure. And 3, so live longer, feel better, and then, as we were indicating before, to do more, to lead more functional lives, to restore health so that you can do more, walk further, be more engaged, get out of the house, not be homebound. Because heart failure, otherwise, when you're still having persistent symptoms, despite being on medications, is a progressive disease. And so that is an indication. And we have gotten comfortable in terms of the safety profiles of the new devices are such that, you know, essentially it's never great when someone's backed in a corner and has to make this decision because they had a sudden heart attack and it's a life or death decision and they've never had a chance to digest or the information about this. So, and sometimes it occurs and we can't avoid it. But what we want people to do is to go in educated, to understand what they're buying into and signing up for. Some of the burden is the frequency of medical follow-up. But we do want you to understand that, you know, there's lots of facets of your life that we expect to improve. There is variable degrees of responsive. I can tell you 80% of patients go from having severe symptoms, that's the indication to put in the device, to mild or no symptoms. But time and time again, we hear from people that have a very slow trajectory, that they've adapted to living sick and it's their new normal. And they don't often realize how sick they were until after the LVAD was in, because they tell me they're feeling fine. And then I met a patient today and their kid's in the corner of the room going, she's not doing, or he's not doing okay. And it's because the person's just used to being sick. They're chronically ill. And then now this device is in and their life is just transformed. And there are limitations. You adjust. There's trade-offs. You're now connected to batteries, right? You have to plan your life around batteries. Although you have more than 2 sets, but if you carry an extra pair, which you always should, that's going to get you more than 24 hours of support. So you don't have a constant fear of, do I need to plug in when you're out and about? And we have people that travel, and the other patients hopefully on the call can comment, but you know, we don't discourage people from traveling to areas of the country where there are facilities available should an emergency arise. But we have patients go to Florida, to California, et cetera. Again, it requires a little bit more thought and preparation, but we want people to live as fully as they can. So hopefully that answered the question. But if anybody else has comments, a patient or the nurses, yeah, Hamid.
Well, I had a HVAD for not for too long, for about 2 months. I was pretty sick in between, but in that 2 months, it was a definite improvement in my quality of life. It definitely makes a difference.
And so importantly though, it is an assist device. These are not total artificial hearts. So you can have residual symptoms of heart failure. It's not a curative therapy. It is a restorative therapy. And so I said 80% of people go from severe to mild symptoms, but that means 1 in 5, 20% continue to have moderate to severe symptoms despite undergoing this aggressive approach, this surgical therapy. My job in the art of what we do is trying to predict, and it's not easy, who's going to fall in that 20% of the population that doesn't thrive, that doesn't do well, despite committing to this therapy. It can be hard. That is a challenge. And ideally in that situation, we really want to avoid that in someone who's not transplant eligible, because we always say if you can go on to get a transplant, then even if you're struggling with symptoms, the device is keeping you alive until you have an organ donation. It's a harder pill to swallow if you're not eligible for transplant and you're still struggling, although it may still be keeping you alive, but you could still have, significant disability related to the heart failure. But the majority of time, people do very well. And we've gotten very good at patient selection and trying to guide people through that, making a decision that's appropriate to them. But that is where I think it's really helpful when we have people that are consenting. We almost always try to pair them with a patient within their age and sex or their gender demographic to meet with them, to give them the real scoop. It's one thing for me to just say what I said, but for them to say, this is what it's really like. And not to hide the complications, you know, the infection, right? Being on antibiotics, the concern or fear of having a stroke and being on blood thinners, et cetera. But the reality is people with heart failure are already at higher risk of stroke, and many are already on blood thinners, but there's other trade-offs in the infection risks, et cetera. I don't know, Nate or Teresa, do you have any other comments or thoughts on that?
Yeah, I mean, I can speak anecdotally, you know, just with my patient interactions, and you know, most all of our patients who have LVADs are happy that they have it. You know, I mean, they're making a hard decision to get one, but sometimes, you know, it's their only option, and they're enthusiastic and living good lives that they consider good lives. With the LVAD.
We do collect, you're right, Nate, thanks for bringing that up. So we survey our patients, and one of the questions we ask is, knowing what you know today, would you go back and make the same decision you made? And almost universally, people say yes. They would, if they had to do this all over again and get an LVAD again, would they do it? And almost universally, the answer to that is yes. Teresa, you had it interrupted you. I saw you were about to say something.
Oh, I did. And we refer all of our patients to cardiac rehab 3 months after surgery. And, you know, most patients before that, they'll ask, when am I going to feel better? And typically after they start cardiac rehab, it's like a, you know, it's like a private gym membership. They do start to get their strength back, and most patients do feel better and get energy back after enrolling in a cardiac rehab program.
So I'm glad you brought that up. So important. I try to tell people, so heart failure is not a disease just of the heart. And particularly when you've been living in it for years, your muscles are in a state of constant oxygen deprivation, and you get changes at the muscle level, and you develop what we call cachexia, muscle wasting and thinness, and that does not reverse just because you have a pump put in overnight. And again, we know from our studies that in terms of people hitting their peak, that can take at least 3 to 6 months, and sometimes longer if you had a complicated course after the surgery. So we try to tell people not to get discouraged, because how you feel on day 4 is not how you're going to feel on day or month 6. So that's absolutely right. And we get people in the cardiac rehab, and then they start to hit their stride often much later in the course of their support with this therapy. And then, you know, so I guess, Teresa, let me ask you, because I kind of know where we stand with Nate as a program working together, but, you know, one of the hardest decisions we would ever make is to, if someone, not everybody had, you know, there are people out there that don't have big families and may live independently. So is that, you know, have you had success for what we know the importance? I think there's nothing more important than being able to have a strong caregiver. It's hard to get through this emotionally, mentally without support, but it is possible. And how much support really is needed in the long term? And do you have patients that go back to living independently and they may just need caregiver support? What are the requirements, the Brigham, for duration of having somebody live with you if you don't have, if you're not married or in a relationship where you currently are living with somebody?
So we do ask, ideally, we say 2 weeks, 24/7, if you can have someone with you post-operatively, just so just for equipment management and just some safety, you know, and then once patient deems they're independent with an ambulatory test and we do a controller exchange, what to do in an emergency with demo equipment, they can be on their own, and their family member who they live with can go back to work, and the patient can be on their own. We do have some patients that they've had caregivers for just a short time and they live on their own, and they're doing well. We do have some patients that do their own driveline dressing change. but they do come into clinic and they show us that they can do it sterilely, so that they're able to do that. So we do have some patients that live alone and actually do their own driveline dressing and have done well. Yeah, you're right. Not everyone has a huge support, and most patients with large families would say, I wouldn't ask my family to be my caregiver, so they go to their friends or their neighbors. You know, we try to work with our patients to make sure that they're safe and things go well.
Yeah, and we hear that you alluded to something. We certainly hear from patients that they don't want to be a burden on those around them. And we never want them to make the decision against a therapy because they're afraid of being a burden, right? Because the goal of this is to help people to get back to independent living. So, but it can be intimidating, right? So maybe the patients can speak to this as well, but you first hear about living on a mechanical system, right? And connecting when you're asleep to a cord in the wall, right? To AC power. It sounds really intimidating until again, you meet a patient with it and you kind of get, the device gets demystified and you realize that plugging in batteries is not so complicated and what seemed very scary. And initially everyone says, no, why would I ever do that? I would never want that. But once you get educated and learn, it is a much, it's not that, again, it's easy for me to say, I don't live with one, but it doesn't seem like it's that complicated with a little bit of planning to be able to live. I don't know, Hamid, if you can comment to that at all in terms of, was it really intimidating at first and how complicated was it to arrange your life around the LVAD before the transplant?
It wasn't, once I had the LVAD, it was pretty routine. I mean, I figured out, my wife did the dressing change outs and basically I managed the batteries and the charging and the car charger, the wall charger. For me, the bigger challenge was coming to the decision to accept that I am going to actually have this surgery. That for me was the harder point, but I was so sick that it come to a point that he said, I'll do anything to make me feel better.
Yeah, and how you know what, it's always humbling on our side that you entrust your lives to us and going in. I just had knee surgery and I was nervous going into that knee surgery, and I just can't imagine on the patient side when you're going into the operating room and you meet Dr. Cooper or Dr. Pham or whoever it may be, that you're saying, yep, go ahead, I need to go through with this. But can you speak a little bit to, and then you may not ever see your surgeon again, the person who does this kind of miracle, but what is that process like for you?
And after that, there's 2 more questions. So when you're done with that, I'll pop in with those. But go ahead, Hamid.
It was, again, maybe a lack of big oxygenation in the brain or whatever, but once at least when I came to the realization that this is a solution for me, I pretty much had resigned and resolved myself to do. But I tell you, when I went into OR, the gentleman that first came up to me was the anesthesiologist, and was just talking with him, and he was trying to explain that, how it's going to be and stuff, and it was very comforting. And no, I did not. After the LVAD, yeah, I think maybe I did still see Dr. Cooper post-surgery. And they come in, the care you get's amazing. I mean, and it's not, I mean, yes, I was at Tufts, but I've spoken with patients all around the country, and I'll tell you, anybody whatever center they've been transplanted, they will swear by that center and put their life in their hand anytime. So it's not something unique to any hospital. It's just the care you get as a patient at these centers is just phenomenal.
Yeah, I would agree with that. Not in terms of herself, but in terms of at any of the centers, you're going to get amazing care by the type of physicians and nurses and middle-level providers that are drawn to this space, I think, for sure. Megan.
Yeah, so I think there might be a couple. So first question was, since the HVAD has unique challenges, have the centers reached out to emergency responders where the patients live to educate them? As a clinical specialist, I can attest that I've been to many EMS and fire trainings for the first responders and done trainings in areas, but I'll have some of the centers reach out as well on that one.
I'm going to defer that to Teresa and Nate.
Yeah, every VAD patient before they're discharged from the hospital, we send information to the local EMS, fire department, electric company, and we offer training to them, but we send all the information out that a patient has an LVAD and just to be aware. And I think that more and more fire departments are more comfortable with these patients in the community.
Great. Awesome.
Yes, and I in terms of I don't know if in the challenges that was alluding a little bit to, you know, some of the the recall of the HVAD device that happened a couple of years ago, but I can say yes. So we always, part of the requirements again of any institution to be certified as a VAD program is to provide education to the community that a patient is returning to in some form. Now, we have patients from across New England, so we can't get there all in person, but we do communicate and send resource material. So there is that training. Now, specific to the HVAD device, I would honestly say, you know, it's the same education that we're providing to any of our LVAD patients, and that's if you have an alarm and that is of a priority, because the different devices have different, the way the alarms or the information is provided is a little bit different, but there's what we call medium or yellow caution versus red heart or red alarms that are high priority. So if there's a high priority alarm that is indicating that you should swap out to the backup system controller, that our recommendation is if you're feeling okay and it's just the alarm, which is provoking anxiety, those could always be temporarily silenced, to call, let us know. You have 24/7 coverage, and that should be done in a controlled environment where you have other resources available. So don't do it at home unless things are unstable and you're not feeling well. And obviously that's a higher stress situation, but if you need a controller exchange, we want patients for that to be done in the hospital or in the clinic with us, should in the unlikely case that there's an emergency. Now, if there is an emergency at home, then call 911 and hopefully first responders are there to provide a calmer set of hands to be there to help exchange to the backup controller. And we would prefer, if you could, to wait for EMS. But again, if someone is unconscious, for example, then you need to switch to power the cables to drive what you're educated to do to a system controller exchange. But ideally, that is done because at the hospital, because these things occur so infrequently that even though we're training you, your training may have been 6 and we may be kind of clinic to clinic asking, how are you comfortable with that? Reviewing it a little bit, but it's never the same as when you have your hands on it and there's an alarm going off that raises everybody's blood pressure. So things can get dicey a little bit if you need to do that at home and you haven't done it since maybe your initial training with the mock circuit that we provide our training with. So anyhow, but that's not unique to HVAD. We've adopted that mantra for any of the devices, and I think it's applicable and wise to do that. The other thing is in terms of the recall, and I don't know if there's anybody on the call, but in general, so there was, what that meant was that there were certain lot numbers, meaning some of the system controllers that were manufactured, if in the unlikely setting that you had an alarm that required back swapping out to your backup controller, that there was a chance that the new controller may not start right away. Now, people with the standard device, that is far less than 1%. I don't know about patients at the other institutions, but we don't have any patients in the high risk category. So the high risk category, that number was a lot higher. 3% of which we consider high risk. 3% of the time that pump may not restart automatically, and there was a very small group of patients that had even a higher percentage than that, actually as high as 30%. But I think there's really very few patients across the country that fall in that high risk category. And if you did, they would have been notified already. So None of the patients we're currently care for do. So the risk of having a fatal event because of that issue is exceedingly low, and no different, frankly, than any other device that we've implanted and have patients on support in the community for right now. At least I understand it from an engineering perspective, as a medical physician.
Great, thank you. Another question is, making a decision is tough for me. My one cardiologist said I had 6 to 8 months to live last year. They put me in the hospital and then ran tests for a possible transplant. I didn't qualify. They talked about the LVAD at that time. I wanted to think about it. When I went back for my follow-up, he said I was healthy and no longer needed an LVAD. How does this diagnosis change? I definitely want a better quality of life and get my energy back. My EF is 20 to 25 or 25 to 30 is the estimate.
I guess that's probably for me as well. It is hard to make a decision. It's hard to comment in detail on that without having reviewed someone's medical records. It is certainly possible, though, as described, for someone to respond to medical therapies and to improve and be in a place where we may now think that the risk assessment is such that now may not be the time for an LVAD, but that may be something in the future to reconsider. However, as I mentioned previously, I do think the technology and the state of affairs is such that if you, again, without having been able to review your test results, but to the point where if you tell me that you're ready to take this leap, based on the quality of life that you have, you don't want to continue living like you're living, given the amount of disability you have, then that would push me to say, okay, let's talk about an LVAD, because it's not just about survival alone anymore. It's also about quality of life and functionality. But people need to know, and again, you need to know the burden of follow-up, frequency of clinic visits. I was going to ask Teresa in a minute what that schedule and cadence of follow-up looks like at the Brigham. But I hope that answers your questions, but things are dynamic, and I will tell you that none of us holds a crystal ball. So one of the hardest things we do is prognostication, meaning guessing how long someone has left to live. And numbers are often, and we predict very poorly, and things can change. And hopefully people do respond to medications. And I'm very cautious when I provide those numbers to people, not because I'm hedging. I'm afraid to be wrong, but it's just really difficult. It's easy to do if someone's in the intensive care unit on IV medications and we see that their blood pressure is dropping as we change medications, to say you won't make it out of the hospital alive without an LVAD if we were just to stop doing what we're doing. It's a harder guesstimate when someone's kind of what we call skimming the trees at home, not really thriving, limping along, to know, is that 6 or 12 months, unless something very clearly is deteriorating. But it doesn't sound like that. The situation here sounds like things have stabilized and potentially, thankfully, improved.
Oh, were you asking me about the follow-up, or is that?
Oh yeah, so in terms of when people, how far out, so right now at Tufts, let me throw it, so we see people weekly for a couple of visits, every other week, monthly, and then if they're destination therapy, we're now, it used to be for a long time we saw them every month or every other month, but now we'll go every 3 months. We would go every 6 if they have a local provider that can participate and has the knowledge, interest, and skill set to assess someone more remotely with an LVAD up in Vermont or New Hampshire or where have you, so to decrease the cost and the travel burden. But people, if they're stable, we still continue to see them every 3 months, but that's not dissimilar from someone with heart failure without an LVAD. I generally see most of my patients every 3 months, and unless they're very mild symptoms, and then it's probably every 6.
That's what we do also. So our stable DT destination therapy VAD patients are every 3 months. Our VAD patients that are bridged to transplant, we see them every 4 to 6 weeks. And that's the difference.
Great. All right, I'm just seeing that I'm doing too much talking. We're at the end of an hour here. So I don't know if people have other questions or things they they want to bring up or ask? Anybody on the panel? Things that I haven't covered yet? Maybe I can ask the patients. I mean, do you think, and I'm not going to take offense to this, but how well, Bob or Hamid, were things communicated to you in advance? If you remember, it can be hard to retain information when you're sick and not feeling well. But do you think, you know, that the medical staff does an adequate job communicating the risks and everything we've talked about today before you go to the operating room about these devices? Did you know what you were getting into? But I mean, Bob, you had, if I recall, and I can share that. I mean, you had some complications. You both did, right? Were you aware that could have occurred, or were you kind of taken blindsided by that?
I was blindsided. I didn't know what I was doing.
You think because we could have done a better job, or just because you were, you know, sick and things happen so rapidly?
I was sick. I was definitely sick. My wife, Susan, just made the decisions for me.
Got it.
No, in my case, I made the decisions, you know. I mean, if I recall, when I first came in and you guys put me with the Swan, there was some discussion of putting me on a VAD, and I just could not wrap my head around the whole process of the surgery. So I went home on a milrinone drip, and then, but my condition continued to deteriorate. So I remember calling back and saying, "I'm ready. Let's get that VAD."
Anyone on the Medtronic team? I know we were, you know, again, really wanted to create a forum, provide support, and Medtronic's been incredibly supportive, ongoing to the longitudinal care of patients still living with the LVAD. Or any things you'd like me to address? I know this, you know, this is organized by the HeartBrothers and us as the care team, but you've got a lot of insight from across the country, probably with similar sessions. Have there been other things that have been brought up on other similar topics that we haven't touched on yet?
Not that I can think of. I think they all just kind of differ, and it's whoever's on the call and what their specific questions or what they're dealing with. I think it's you know, dependent. So I can't really think this was informative, I thought, but I'm also not a patient. I'm on the other side. So yeah. It was great though. Thank you.
Well, no, thank you. And thank you for continuing to support our programs and our patients.
So the only comment I have, and again, this goes back to Megan and her team, is, are there questions that you wish had gotten asked here that didn't get asked because we didn't have the proper patient population, that the answer would be worth to people once they go back to the
good question. Right. Meaning we did prepare, and I had somewhat of a script that I've gone off script a little bit just because some of the questions are directed more for audience members to answer as it relates to what their experience has been with this device. What could we be doing better as a community? What resources would help make things better? You know, those are things that we're hoping that HVAD patients could share with each other more directly.
Right. And we would love to hear those answers as well from the patients. All I can say is, coming as the clinical specialist who covers here, is that we're here for you, and I'm a phone call away. We are going to hear and continue to support you the whole ride through. We're in it all together, and you know, we care about it, our you know, the centers, and making sure, you know, your VAD team is up to date on everything, and being transparent about everything that's going on. But you're not alone in this. So as I said, I'm a phone call away. Everyone knows how to get in touch with me. So, you know, I think I can stand for everyone from the Medtronic side. We're here for you. So
yeah, I can attest, and obviously I'm not a Medtronic employee, but I can attest that I've been very pleased with the response from the company and the frequency of communication and the level of commitment that's been shown to continue to support patients while not still actively offering this therapy to new patients in the future has been great. So I don't have any concerns as a provider from that perspective. Good. Well, hopefully this was helpful for people. I appreciate everyone's time tonight. So thank you, and thanks again to the Heart Brothers for organizing and letting us all be part of this. I don't know, Teresa or Nate, if you have any other kind of final thoughts you wanted to bring out, things we didn't discuss. Okay. Good. Mead or Bob, do you have anything else?
Just thank you. Thank you very much. I know everybody on the clinical side is very busy, from you, doctor, all the way to Teresa, Megan, Nate. So making the time available after hours to do this, it's greatly appreciated. So thank you. On behalf
you're
of
very welcome.
patients,
Yeah.
thank you.
I think these support groups are obviously so important for people because there's a lot of uncertainty and it can be a very scary time in people's lives. Awesome. All right, everybody, have a great night. It was good to see you all.
All right. Thank you.
Night.
Thank you.
Bye.